Okay, welcome everyone to our monthly developmental disability clinical and research rounds. Uh, this month, what I've wanted to do for a while, I've tried to get other people to join me, but people were a bit reluctant for a variety of reasons. What I want to do is talk a little bit about the difficulties we have in providing services to people with developmental disabilities in terms of people with severe behavior problems, and how it seems to me the developmental sector as set up or optimized or even able to cope with acute crises or acute worsening in people's behavior and some of the problems that presents for families. So let me first of all uh, share my slides here. And so I think as with my presentation a few months ago, I would like to really make this as interactive as possible and engage people as much as possible in discussion about what they've noticed as difficulties in the system, but also if there are possible solutions that we have, because it is an ongoing problem, and I don't see it getting better in the coming years personally, unfortunately. So I have to give uh, sorry about that. All right, so first of all, I have a few theoretical conflicts of interest, but they have absolutely zero bearing or implications or impact upon my talk today. And these are the learning objectives as well. So I have to give a hat tip to Charles Dickens' A Tale of Two Cities, where the line, "It was the best of times, it was the blurst of times," with a shout out for anybody who knows that. Laura, somebody had a question or something? Laura, I think, and I don't know what happened here, Jason. I can't even see that part of things anymore. Oh, here we are. Hold on.
I don't see a question from anyone.
Oh, there was. Okay, somebody had their hand raised, but now it's down.
Ah,
Okay. And I don't even know. Oh, I'm completely lost now, to be honest with you. So let me stop sharing that and then restart. Uh, okay, over here for a second. Okay. All right. So I want to talk, first of all, I just want to talk about a case that sort of highlights this, and then we can sort of, what I see as the problems that we have inherent in our system. So a boy by the name of Corky Buchek, and that name comes from a specific movie. If anybody has seen it, they will remember it. But anyway, that's not this kid's name, that's for sure. He's an 8-year-old male who lives with his parents and his 3 younger siblings. He is registered in school and has never attended consistently. So he's gone periodically for an hour at a time at most. Uh, in part because there have been a number of family moves over the years and difficulties with registration at school, but has never actually attended school on any consistent basis at all, which just puts more stress on his family, I think, over time. And he was referred to us for an assessment because of severe aggression and ultimately almost an inability to leave the family house. And this is not an unusual referral that we get around severe aggression and or self-injurious behavior. And the problems that presents and with treatment. So his parents noted problems with his development early on in his life. They said his mother said at the age of 1, she really noticed that he didn't seem to be like other kids in terms of response to other people. He wasn't babbling. He wasn't trying to communicate. She said he was actually a very easy baby and very quiet and didn't fuss a lot, but also noticed that things like rolling over and sitting up seemed to be behind as well. So at around the age of 1, a little bit older than that, the family went to their family doctor with their concerns, and they referred to a local agency for speech and language therapy and for further assessment as well. He saw a speech and language pathologist for therapy and also saw an occupational therapist, but didn't make gains the way people assumed that he should or would. And the therapist also noticed problems with his social interactions and its responses and things, and suggested that he should be assessed for other developmental or mental health diagnoses. So later he was seen by a pediatrician and was diagnosed with autism spectrum disorder and global developmental delay. He has never had a psychological assessment regarding his overall cognitive ability. I don't think he's able to participate, and I don't think he'd be able to do the routing tests even on the Stanford Binet. But at the age of 7, somebody completed the Vineland Adaptive Behavior Scales with his parents, and there were significant delays in all areas of his functioning. So all of his areas were below the 0.1 percentile and below the age of 3 in terms of functioning. And for some measures, the lowest you could get was below the age of 3, but for other measures where you could go lower, he was functioning below a 1-year-old age level in a lot of areas. So very, very disabled. And although in people with significant cognitive deficits, diagnosing autism and intellectual disability can be very difficult. In this case, because of some of his repetitive behaviors and his stereotypes and things, it was pretty clear he also had autism spectrum disorder. So his diagnosis at that point was revised to autism spectrum disorder and intellectual disability at the severe end. But I mean, he had those diagnoses in place when we were asked to see him. So his behavior problems have always been very, very difficult from a very young age and very challenging for his family, and typically were associated with frustration. So things not going the way he would expect. So typically things like being told no, having to do things he didn't want to do, having things taken away. If the Wi-Fi goes out when he's playing a game or something like that on his laptop or on his tablet, he would get very upset and break things. And when he was upset, if there's aggression, typically it was towards his mother because she spent most of the time with him, and he would hit her and scratch her and pull her hair and things. She's not a big woman, and already by the age of 8, he wasn't as big as her, but was getting to that point, and I think she was somewhat afraid of him, frankly, because of his behavior. At other times, he would also engage in pretty severe self-injurious behavior, including banging his head on really hard surfaces. And his parents were very concerned about what that meant. They asked about concussions, whether he'd had one, uh, and things along those lines. So there's obviously a lot of really problematic behavior because of his behavior and other difficulties. So he'd never really attended school for more than an hour a day. And in fact, he went for several years without going to school at all. Again, partly because of moves, difficulty with registration, but because of his behavior. So when at school, when he would be aggressive, again, typically towards adults, but they had a really hard time managing it, especially as he got older and bigger. And so he was being sent home frequently. He was never formally suspended from school, was never excluded from school, but was sent home on a regular basis. And his parents at times felt that it wasn't almost worthwhile sending him because of what would happen. So if he had a really difficult morning, his parents just wouldn't send him to school. The other difficulty they had, though, was that he was really very much against going out of the house a lot of the time. And so his parents would have to sometimes carry him out to the car and he would be fighting and hitting them. And it was never clear why he didn't want to go to school and what it was. But it wasn't just school, it was going anywhere. So even over the time I've known this family, there have been a number of times where we've had to change appointments from in person to by video because he wouldn't leave the house. He has shown up at appointments wearing slippers and pajamas and a house coat, even in the middle of winter. And his mother was saying, even getting him sometimes to leave the porch at home or the front door would be really, really difficult. Even just to get him to walk out across the front lawn to the sidewalk. And it didn't appear to be related to anxiety or anything like that. And so we're not clear also because of his lack of communication why that is. But what it has done is it's really limited his ability to participate in any community activities because of potential for behavior problems, but also because of the uh, just difficulty getting him to leave the house at all. And this obviously has an impact on his younger siblings as well because they're not able to go out and do things as a family. The other issue that his behavior has created, apart from his sort of mother getting hurt sometimes, is that one of his younger siblings has a pretty significant anxiety disorder, and one of that siblings' focus of anxiety is their mother. So when this person is at school, they will often call their mother or ask to call their mother and want to talk to her, and will check in. Are you okay? Did you get hurt? Did Corky hurt you today? Were there any problems? And constantly asking his mom, even at home, would check in on her regularly. And this interfered with his education, but also with his well-being overall. So there are a number of problems presented by his difficulties and his behavior. So in terms of his past medical issues, generally he's been very healthy. Corky, as there has been, he's never been hospitalized for any reason. There's no history of operations. He's never had a seizure. He doesn't have any allergies at all. Somewhat surprisingly, his vaccinations were up to date. I'm not sure how they were able to get them done, to be honest with you. And he had also, when he was young, had genetic testing which with a microarray which did not reveal any abnormalities. He, when we saw him the first time, wasn't taking any medication. and was not taking any supplements. His diet is fairly narrow, but was able to eat something from all the food groups. So was getting essentially what the nutrition he needed, although it was fairly narrow. He had I forget the name, some kind of myelocele on his spine, I think, which turned out to just be a fat pad or something that they, when he had an ultrasound, so it wasn't anything significant, had no implication on his motor functions. He wasn't delayed in walking. Well, he wasn't delayed in walking. He walked by 16 or 17 months, but also it didn't cause him to have any problems with his motor abilities. Uh, in the family history is something. So one of his younger siblings, as noted, has attention deficit hyperactivity disorder and a fairly severe anxiety problem. And another one of his siblings, because of ongoing difficulties, has been admitted to hospital and to other residential facilities because of mental health problems. So for the family, it's a huge amount of stress and difficulty, first of all, because of this boy's behavior, but also because it impact on other family members and on everybody in the family, really, ultimately, which has created all kinds of difficulties for them. So I don't really have a lot more to say about him because I don't want to make it the focus, but just sort of the difficulties he presents. So when we saw him the first time, they had not received any intervention at all, and they had not, or behavioral intervention or medication, and weren't really sure what to do. Didn't have openly acknowledged they didn't have a background in children with developmental problems and weren't sure how to manage his behaviors at all. So for now, let me just stop there. And if anybody has any questions about this person or before I proceed with talking about the main focus of what I want to do, if there's any questions or comments, either people can raise their hand or put it in the chat or the Q&A or whatever they want. Okay, so either it is completely clear or completely unclear. But as time goes on, I say, if people have questions or comments, please feel free to interrupt me. Okay, now, where am I? There we go. Sorry. Okay, so he's always had these difficulties, and his parents weren't sure where to turn for help with managing his behavior. They had registered for the Ontario Autism Program in its current form, but had not yet received services. So first of all, what I want to do is go back and say, okay, so what is the history of the Ontario Autism Program? And I think these difficulties apply also to people with intellectual disabilities who don't have autism, but OAP is an easier place to start in some ways, I think, because in theory, there's more services available. So the Ontario Autism Program was introduced in 2000, and initially it was a very specific purpose. It was intended to provide what's called early intensive behavioral intervention for children under the age of 6. And so it was intended to be modeled on the work of Lova, where he reported back in the 60s or 70s that children with autism, if they received intensive intervention prior to the age of 6 and really around 2 or 3, that by the age of 9 they were indistinguishable from other children. I have some issues with that statement, but certainly there's evidence that it can improve people's developmental trajectory. And it's called intensive because it was meant to be Lova's claimed 40 hours a week, but at least 30, I think, was a minimum. And it is prohibitive in terms of cost, but the goal really is to improve people's trajectory so that they don't require services as they get older. But since the program started in 2000, it has been beset by numerous problems. I think that the government had no idea, they had no idea what the demand was going to be at the time and what was going to happen in terms of diagnosis of autism, obviously. But initially, even early on, so I think 2004 or 5, the first lawsuits, it was Weinberg versus Ontario and Deskin v. Ontario. They claimed that because the program was only available for people up to the age of 6, and there was no provision for intensive behavioral intervention in schools or in special education, that it was therefore discrimination by age, which went against the Charter of Rights. So initially, the court in Ontario said indeed that there was evidence of discrimination by age, and therefore the government had to rectify that. The governor of Ontario, and this I should say is a really brief overview. There are all kinds of nuances to this I'm not touching on, but anyway, the province appealed this to the Court of Appeals, and they actually overturned the lower court, I think saying that there was no obligation by the government to provide these kinds of services to people, and therefore there was no discrimination by age. The plaintiffs in this case appealed to the Supreme Court of Canada, who dismissed their appeal, and they never heard it. So the way it stood was that it was going to be there was no obligation on the part of the government to provide services past the age of 6. However, after the government won their lawsuit, they then stated, however, that they were not going to that despite the fact they had won the lawsuit, they were actually going to change the program and provide services for children over the age of 6, which makes me, as a non-lawyer, wonder why they pursued the appeal in the first place, although it may have been for the principle of it. But also, I think what happens is sometimes where we have to be careful about what we wish for is that there's a finite amount of money for the program. And if the program was then, if they were going to offer it to everybody up to 18 or some kind of intervention, that meant that the amount of money available for any one individual was going to be less. And given that the cost of early intensive behavioral intervention, the 30, 40 hours a week is quite prohibitive, that meant there'd be less money for them and for that service and that program. So because of this, the government of Ontario then in 2006 created what they called an expert clinical panel for the autism intervention program. And a report was then created for 2006 and developed what they call clinical practice guidelines for delivery of intensive behavioral intervention. And I was involved with that. There was a really thorough literature review, and we met weekly, and it was pretty intensive in terms of the amount of work we had to do, and the literature review, and came up with a series of clinical practice guidelines, which were seen for the early intervention program, which was seen as aids in making clinical decision making, and how do we get the access, allow the most number of children with the most needs to access services, and also ultimately to see that in terms of early intensive intervention, not as all of the Ontario Autism Program was, but it was one in a range of services for people with autism throughout their years of childhood and adolescence. In particular, there was one practice guideline that created a whole bunch of controversy and backlash and for the government. So one of the guidelines recommended creation of benchmarks or goals which would be used to demonstrate progress in therapy. So the idea was that at the time that everybody with a diagnosis of autism would be eligible for services through the early intensive intervention program, especially under the age of 6, but that if people in therapy would have to demonstrate progress over a period of time in order to continue in therapy. And although that may sound a bit draconian or a bit harsh, I think it's not different from any other treatment where if people aren't making progress, aren't improving, we want to step back and then say, okay, is this the correct approach, or do we need to consider other interventions? In particular, children and adolescents, I think, young children with more severe intellectual disabilities, the evidence for benefit from early intervention and intensive behavioral intervention is less. And so if people aren't making gains, perhaps it's something that we need to think about, a different form of intervention for them. And so what that guideline basically said was that in order to continue in IBI, there should be specific, reasonable, and relevant benchmarks to demonstrate benefit, especially in language, cognitive ability, and adaptive behavior. And that they should be set out in advance and be very transparent so that people would be able to know what goals were aimed for and where they should be focusing their efforts. However, I think the idea of benchmarks was misinterpreted at times, and the word is perhaps used incorrectly at times also, and created a tremendous backlash for the government. But before that happened, the backlash, or at the same time, the government actually established an independent benchmark panel in order to provide transparent and consistent guidelines for clinical decision making. So it'd be sort of across the board, not a one size fits all, but a general guideline to make sure that everybody across the province was receiving treatment and had the same goals and needed to show the same progress in a way that was equitable for all, and that the program was effective. And so this committee for the development of benchmarks was created, and they submitted a report to the government. However, because of the backlash from various groups, and the concern on the part of the ministry about what was happening, They actually sent letters to providers indicating the clinical practice guidelines that had been developed and which they had received a report on should not be used, and benchmarks should not be created by any other panel. So after creating a committee for developing these benchmarks, which to me seemed like a reasonable idea, because of the public scrutiny, or not scrutiny, backlash, I guess, they then scrapped that idea entirely, which was problematic for many reasons. So the program continued as it had been, but now providing services up to the age of 18 in theory, but still often intensively. And so obviously there were costs, and we'll come back to it in a moment, about concerns about the costs and the expense of this and the number of people being served. So then in 2013, the government established a second autism spectrum disorder clinical expert committee. And a report was developed initially. The first one was submitted to the government in December of 2013. And basically, the whole point of this panel was to review the clinical practice guidelines and benchmarks and provide further and updated recommendations that were appropriate. So the committee at this point was then responsible for several things. So one was reviewing and analyzing evidence-based research on treatment, services, and supports for children and adolescents with autism spectrum disorder, to provide the Ministry of Children, Community, and Social Services with advice on up-to-date and evidence-based treatment and research in order to inform policy design and program development, provide advice to the Ministry on treatment, services, and supports, and then provide advice to the Ministry on the implementation of clinical practice guidance and benchmarks that would have an impact on how autism services are delivered. And this, so the first committee, the 2006 one, had it was largely, well, it was all professionals with either psychologists or speech and language pathologists or occupational therapists. I think there was about 10. But one of the people on the committee also had a child with autism spectrum disorder, so they were able to provide a parental perspective on things. And the same with the 2013 committee also had several people, largely professionals, but several people who also had children with autism, so could provide that perspective as well. So the recommendations that the second committee provided, and this is where it becomes a bit problematic in terms of the fracture of the program, they said the government should continue to provide early intensive behavioral intervention for children under the age of 6, and at the same time develop criteria for consistent decision-making in terms of progress and the ability to stay in the program if people aren't making progress. Second recommendation they made was developing a framework for consistent clinical decision-making in the province. And again, having been on this committee as well, one problem that came up was that getting data on, so at the time, people could either get direct service, so they would be provided services through an agency such as Thames Valley Children's Center, so it was referred to as DSO, but that wasn't not the same DSO we know now, so develop direct service option. And there was also a direct funding option, so people could get funds and then pay for them through a private organization. It was difficult sometimes to get data, particularly on non-IBI, so not the intensive behavioral intervention, but more applied behavioral analysis services for older children, to get data on the numbers and the goals, and progress was very, very difficult, particularly from the direct funding providers. And I think that was the other issue, was develop a framework for data collection. Finally, one of the other things that was recommended was there should be a continuum of care for children and youth with autism from childhood up until adulthood. So there must be appropriate services, but they're not necessarily limited to only early intervention and ABA-based interventions for older children, focusing on specific behaviors, but also looking at communication and mental health services and having that sort of continuum and then seamless transition into adult services, which is a great idea, but hard to implement in practice. And so this, again, it's hard for me to judge how much impact this actually had on the Ontario Autism Program and the provision of services, but it created other problems. And due to ongoing concerns about the program, as well as a ballooning cost, which we'll come to in a moment, and the exponentially expanding waiting list, it was clear that something had to change. So in 2019, so the government again struck another committee. So this will be the third one in 13 years to examine and consider changes to and the implementation of the Ontario Autism Program. And I think the fact there were three different committees in 13 years providing recommendations, which were at least the first two were similar but not identical. I think that says a lot about how disjointed the program was at times and how it was difficult to know what the future direction was. I was at a meeting with one of the first committee in about 2006 or seven, and we had a meeting with a variety of stakeholders, including service providers and parents, and some people from the ministry. And one person asked them, what's the goal of the Ontario Autism Program? What was the purpose of it? And at the time, unfortunately, there was no clear answer. And I think that created a lot of difficulties just in terms of what the direction should be, what the goal should be, who the service was for. So was it for people with more severe problems so that we could sort of ameliorate those problems, provide them with a better quality of life, and ultimately, hopefully, lower costs? Or was the program meant to be for much more cognitively able and less severely affected people in order to provide them with an ability to become productive, contributing members of society in the long run? And it wasn't clear who it was for. So it was really, I think at the time, a program where it was sort of everybody's needs were going to be met, which makes it really difficult to provide a specific focus. So this committee then provided a report in October of 2019, and the committee was consisted of a variety of different people. So there were many more stakeholders in terms of parents who had children with autism. There's a few people with autism on the panel, as well as advocacy groups, in addition to professionals and representatives of professional groups. And so ultimately, what the panel at this time was asked for was to provide recommendations that would help to inform an approach that's responsive to the individual needs of children and youth to improve their long-term outcomes. And so at this point, what they said was, it has to be needs-based and address individualized needs of children and youth. So I think the idea of being needs-based was that there had to be some demonstration of what the need was on the part of the child, what was the purpose of the intervention, and what was the need for it. At the time, they said that there was going to be an annual budget, and the program had to be sustainable within an annual budget of $600 million. The year after this, in 2020, the Financial Accountability Office provided a report and a review of sort of financial stuff. And it said there was a few ways that could be done for $600 million, but it would have to change the program radically. The other goal that makes it difficult to meet $600 million budget is that it should be able to serve as many children, youth, and families as possible. And just for context, when the program was started in 2000, I think at the time the estimate was that it would be about $15 million a year. And so by 2019, they were wanting to contain it within a $600 million budget. So it had grown tremendously. The other part of it was that there had to be a line to coordinate with schools and the health system to facilitate a child and youth-centered approach. And again, this is a fantastic idea. I think we all know, however, that coordinating and integrating services is really, really difficult. And getting different organizations to work with each other is not straightforward or easy at the best of times. So they provided a number of recommendations. So first they said was that people with a diagnosis of autism up to the age of 6 should be able to access autism-specific evidence-based early intervention programs on a time-limited basis. So really the idea of having intensive early intervention up to the age of 6. And one of the people on the first panel, Wendy Roberts, who was a pediatrician in Toronto, I thought had a fantastic idea. Her idea was that, children with any kind of early developmental difference should be sort of funneled towards early intervention services, not necessarily autism-specific ones, but providing more access to speech and language therapy, autism therapy, occupational therapy, and things like that, so that it's available to everybody. And then if people are diagnosed with autism, they could then sort of be shunted off to a more autism-specific track, as long as they're under the age of 6 for the early intensive behavioral intervention, as Lovaz had suggested. I think that's what the idea here was as well, but it was never, to my knowledge, completely implemented because of a variety of difficulties. The second recommendation was that children and youth who met certain needs-based criteria through some sort of process which involves their needs-based assessment now should receive short-term episodic evidence-based mental health services prior to receiving OAP core services, which would be the core services being applied behavioral analysis, speech and language therapy, occupational therapy, and mental health services. I don't want to sound overly defensive, but it's certainly striking that given they were recommending that mental health services really need to be a part of core services, I think it's noteworthy that there was no psychiatrist on this 2019 panel to talk about that. And what I mean, there were certainly psychologists but in terms of other mental health services, particularly medically based ones, there was nobody to sort of comment upon that. And so this will be available then if prior to receiving OAP core services that, and then people would get what they call their core services once they're available for the program, once they're eligible for it, once they've come up on the waiting list. What they also said at the time, which has not yet happened to the best of my knowledge, is that they said until there's a significant decrease in waiting times for the program, which had gone the opposite direction, it increased continually, it's recommended that an annual service cap and discipline-specific service caps be provided so people, I think, in order to reach the most number of people, but that each child will get a certain amount of service for their problem. And then when they reach that cap, they have to go back to the bottom of the waiting list. However, I think if we go back to the case that I talked about a few minutes ago, I don't think interventions for something like that are going to be time limited in the sense of it's not going to be short term at any point in time. It's going to require ongoing intervention because of the demands of those kind of severe behavior problems. And so having the idea of time limited things becomes really difficult. And I think that's still what is the case. And finally, what they also recommended for people with severe problems was that an urgent response program be developed that families can access urgently if there's severe, urgent, or acute problems, and would include sort of more service coordinations, respite for families. I'm not sure why. I mean, I can understand the access to a registered dietitian, but at the same time, I'm not sure why that was put in here. To be honest, if anybody knows, I'd love to hear that. And then also sort of intensive short-term access to the core services I mentioned above. But again, if we go back to the boy I was describing earlier, providing 12 weeks of access to a behavior analyst, it's certainly fantastic, but it's not going to be anywhere near enough to remedy that problem or even begin to remedy it, I think. And so there have been continued problems, and this is the program as it stands now, but there are continual problems with it and lengthy waiting lists. And we know that from a variety of sources. And I don't know if anybody has ever seen these figures, but it's from the Financial Accountability Office of the province. They put out this report in 2020, which had some great information. And then also from data since then provided by various organizations through Freedom of Information applications to the government. So at some point in time in the last few years, the government has actually stopped publishing the waiting list and the number of people receiving services. And so in order to get that information, I think a Freedom of Information request has to be submitted. So this is the cost of the Ontario Autism Program as it's grown over the years. So in 2004, it was, I think, 60 million or something like that, which is an increase from 12 million in 2000. But since then, it has grown incredibly. So it's grown by 1,062% over the 21 years. And it's gone from about 60 million in 2004 to 712 million, roughly is what it's estimated in 2025. We don't have the full cost yet. So the average annual growth rate is 13.6%. And just for comparison, if we had all invested in the Dow Jones Industrial Average in a tax-free savings account in 2004, we would not have had the same return as the increased cost of the Ontario Autism Program. So it's clearly outstripping any government income and things. So it's grown tremendously. And it certainly doesn't look like it's slowing down anytime soon, apart from in the early 2020s for whatever reason. The other thing along with that, though, if there is more and more money, we would expect that the waiting list would get shorter and shorter. And in fact, that is not what has happened. So from 2004 to 2011, it grew. It's difficult on a graph to provide all that information because it's grown so much, but it was fairly small and fairly consistent with small growth. To be honest, I'm not actually sure what happened in 2011. If anybody does know, I'd love to know and hear that. But in 2011, it started increasing and skyrocketing. And so in 2025, it was estimated that the waiting list was about 67,000 children. And over the last 21 years, it's grown by about 38% annually, which really doesn't make a lot of sense given that the government has put more and more and more money into the Ontario Autism Program. And I have some theories about why that is, but I'm not sure we'll talk about that later, I guess. But this is a huge amount of growth over the years. And what one organization recently suggested, first of all, we know the waiting list right now is 4 to 5 years. So from the time people are on the waiting list through Access OAP to actually getting their needs interview and receiving funds for services is 4 to 5 years. And unfortunately, that almost negates the whole idea of really early intensive intervention because if people, even if they're diagnosed at 2 or 3, if they're not getting services till 5 or 6, till 7 or 8, the whole idea of early intervention, it's not lost, but it's really diminished. The other thing that's happening right now is that, so it's estimated about 20,000 people are receiving services, but 67,000 people are on the waiting list. So therefore, only about 20 to 25% of people actually registered with Ontario Autism Program are receiving funds or services at any one specific point in time. And so this is obviously a huge problem because the number of people not receiving services or funds is tremendous. And it means their needs aren't being met. And so again, if we go back to the boy that I presented earlier, I think he's sort of a prototypical case that we see here at CPRI a fair bit is people who just are not eligible to get services. Uh, and some families are able to pay out of their pocket, but really for most families, it's really prohibitive. And there are some organizations such as CPRI that have direct service for families, but our availability to keep up with the need is not nowhere near what it should be. And so that just the waiting list gets longer and people's needs get greater and greater. And if we think about the boy I talked about earlier, his problems then become less and less addressed, and problems compound because he's getting bigger and stronger. Just personally, what I try to tell families all the time is that when it comes to interventions for children and adolescents with autism, and I think we can apply this to children and adolescents with intellectual disabilities as well, is that I think medical interventions are the least important thing, right? The most important interventions are education, speech and language therapy, behavioral interventions, social skills training, occupational therapy, all those kind of things are the most important interventions. That medicine, if it's used, should be seen as a way to help people be more available for participating in interventions, but also then being able to benefit from them, being able to use the skills that they learn. So I think about it that medicine, when it's used, should be seen as a way to enhance or facilitate other interventions. The concern I've had for a number of years is that because of difficulty accessing services, medication is going to be used more and more and more, and it's going to become, in some ways, the default intervention. And unfortunately, I think that's what we're seeing at times, which is not adequate or appropriate in any kind of way. Um, Let me so I think there were a number of questions and answers, so I'll try and answer some of them now. Um, so Nicole Neal put in the chat here that the government of British Columbia had a new announcement. Nicole, do you feel comfortable just summarizing that for everybody if I ask you to? Let me go back to where it is. All the participants. If Nicole, do you feel comfortable talking about that, or would you rather not? Oh, so one hand up. Where is that? I actually cannot see whose hand is up right now. I'm not sure. Jason,
They
can you?
lowered it.
Okay, all right. Well, then,
Nicole's got her hand up now, though.
okay, thank goodness. All right, Nicole, all you have to do is unmute yourself.
Yeah. Yeah.
Yeah, sorry,
Fine.
sorry for putting you on the spot, Nicole, but
No, I was chiming in. I was like, there's no chat. I can't just post it in the chat. I have to post it as questions.
yep.
Yeah, BC announced today that they're expanding their early intervention to multiple diagnoses. They're doing a big overhaul of their early intervention program. Because you were talking about the recommendation around expanded eligibility for early intervention here. That's what they're doing now. So we'll see what that looks like and if that has any collateral effects. And then around 2011 was the expanded eligibility of the IBI of the needs-based program. So that's when it I think that was the age expansion.
Okay. But so then, Nicole, when you say they're going to expand diagnosis, that means, because I think the group of people who've often been left out of these kind of things is kids with ADHD who have severe behavior problems or people with intellectual disabilities. So what you're talking about with BC, and I'm not asking you to speak for the government of BC, but are they essentially saying that they will then provide more services to those other groups as well?
So yeah, so they're I don't know what the diagnoses, like all of them, but they're suggesting they're expanding their early intervention to not just autism. So they're like Down syndrome, other developmental disabilities as well. I don't know about ADHD though.
But which makes sense because I think we've seen that people with intellectual disabilities often have significant behavioral disturbances and obviously deficits in their development. And to only make it available for one group of people seems, well, inequitable. We saw a boy, 5 or 6 years ago, who was 5 or 6 and had significant cognitive deficits and also had severe behavior problems. And I remember when we said to him, because he clearly didn't have autism spectrum disorder, and when we said that to his mother, she started crying and said that then how is he ever going to get any help? And I really empathized with her at the time because of the fact there's so much emphasis on autism, which I don't begrudge anybody, but it means other groups I think are being left out and not being included in those kind of things. So if BC's doing that, I think that's a great start. And so Pamela Block, who we heard from last month, her hi Pamela, I had a question about how Ontario compares to other provinces. So I can't speak directly. I think in Alberta, they have a similar program where people get funding to purchase services. They had it long before Ontario did. I don't know how well it's worked in those provinces, but I think that every jurisdiction in North America, I think, has some form of government funded intervention. But I think the costs have risen dramatically along with the increasing diagnosis. And I think the diagnosis is a huge problem here too in terms of getting services. Because I think I've known people say they would provide a diagnosis in order to get services, which I understand that, wouldn't agree with it, but I understand it. But now it's actually creating more problems for people. Dr. Ogilvy, you had a comment? You just have to unmute yourself.
Can you hear me?
Yep.
I guess point I just wanted to make was that the people can be accessing services that 5 to maybe even longer wait times for the core services. I mean, we could debate adequacy of service, but if families can get registered, they can get into the caregiver mediated early programs, which is essentially what we're talking about with some of those early intervention, like the social ABCs, Jasper, pivotal response therapy, what they choose. I think it's not always as straightforward or family friendly in some cases, but it's making sure we're distinguishing between that, what they're waiting for and what is available. Unfortunately, the age is the big mismatch right now between pressures for assessment and wait times in clinics, and when they can get into those services. So that creates some problems. But I just wanted to make that clarification.
Thank you, Jackie. That's a really good point. I think what I'm thinking more again is the people that I see, sort of people with really severe behavior problems who need professionals involved. That training parents, I think, is an integral part of that. But like the boy we're talking about here, or other people that we see with particularly severe self-injurious behavior, and I think it's them that waiting 4 or 5 years, and I feel terrible for parents, and I'm sometimes not sure what to do, to be honest with you, because it's just not available, unfortunately. So the other question that Jackie had here in the chat or Q&A, if anybody has an answer, is that in 2000, after the 2019 report, or since then, the age for early intervention and getting that amount of support and funding early on went down from 6 to 4. And if anybody has any knowledge of why that happened, but what also happened with that then is if people typically don't receive a diagnosis till 3 or 4, obviously they're not going to be eligible for services. And there's also the waiting list as well. And so the difficulty with diagnostic capacity and service entry becomes a huge problem. The other thing, so Claire, if you want to go ahead and unmute yourself.
Yeah, thank you.
Yep, nice to hear from you.
So I do think that 5-year time frame is really, not sustainable. And I'll just pick a child who I saw today, who's 3, to tell them you're going to get money, but when the child is 8, just doesn't seem like a very good system at all, and is not really addressing early intervention in the way that it was the idea, which is kind of early and prior to kindergarten. And it definitely doesn't help people who have severe behaviors now. Like 5 years is way too long to wait. So I just think probably they need another one of these committees, because if that money was redistributed into was what Jackie was mentioning, the services that are available, which are quite substantial really, but just delivered in a different model, then we might have better services in that early intervention time and more money for things like urgent response, right? Which,
Yep.
if it was quickly available to more people would be better, I think. And anyway, it just seems that the money is a sort of a mythical amount of money in 5 years. I suppose I'm a bit cynical. I feel like it might not even be there at all in 5 years.
Well, but not at the way the current growth rate is tremendous. Again, if I would be thrilled if my RRSP had the same return as the increase in Ontario Autism Program funding. But I think that, and again, but this is where we have to be careful what we wish for, because the whole point of the program initially was that for children under the age of 6, and then the school boards were supposed to take over it. They weren't aware that was a huge issue. But really, that's what the initial intent was. And there's fairly good evidence that early intervention can make a huge difference. But now, because of the fact they've had to expand the number of people involved or the age ranges, that there's a finite amount of money. And I believe there have been lawsuits against them. I don't know what the outcome was or what happened, about the fact that as people get older, the amount of funding they're eligible for declines. And again, is that discrimination by age? And I saw it just in last night when I was looking something up, that one of the families in the original lawsuits against the government is now suing the government again because their child is over 19 and there's just a lack of services and funding for them. And especially if they have severe behavior problems. And I think what's going to happen ultimately is that, well, we see this in adult services too. There's just not enough funding and there's not enough services. It's going to hit, well, if it hasn't already, it's going to hit a critical point eventually where it's going to really have an impact on people, unfortunately. And I think we're already seeing that, really. All right. Any other questions or comments before we move on? Okay, let me, Dr. McLean raised her hand, and Jennifer, go ahead and unmute yourself.
Hi, Rob.
Hey, wonderful to hear from you. How are you?
I've talked to you for a while. I just wanted to let you know that PONDA, the Physicians of Ontario Neurodevelopmental Advocacy Group that I'm vice chair of nowadays, but that group has sent a letter on to the Honorable Michael Parson from Ministry of Community Children's Social Services about the issues that we're just dealing with,
Yep.
and the long wait list, and obviously the moral distress for us is, people who see these children not only diagnostic but looking for intervention issues, saying, this is just totally untenable. And is there any way that we could meet with you to discuss some options and solutions? And one of the things we wanted to bring back was, remember when they used to give out interim funding?
Yep.
At time of diagnosis, 1 and 2 payment kind of things to get people started. And the whole point of that was for early intervention. That was the whole point of it. And so one of the things we wanted to meet with them and ask for, we haven't heard from them yet, but ask for a meeting was to discuss some options of that and how this is just not tenable.
It's not easy.
But I think, I mean, one, you're right, Jennifer. I think, and I wouldn't, well, dispute anything you say, to be honest, but I think that the other issue we have is a finite amount of money, right? We cannot.
Yeah, of course.
Any
And
more
that's
money.
the other,
And
and
so
that's
who-
the issue, right?
Right, so who is the program actually intended for? What is the
Yep.
goal of the program?
Mhm.
And I think along with that, well, I think my feelings about diagnosis of autism are pretty clear to people. And I think that's the other issue is we need to really think about what the diagnosis is and how we're making it. Because so then, well, and sorry, you just submitted that or sent that to somebody recently?
Yeah, beginning of January, we just submitted it to the Ministry of Community MCCS to ask for a meeting, and Empower Kids has also
Yep.
submitted asking for a request for meeting, and it's really to get back together. And like you said, it's time to revisit this issue. Where are we going? It's a finite amount of money. The money's increased substantially. The amount of children being diagnosed has increased substantially,
Yep.
right? This is not tenable. We need some further solutions and discussions about this.
But along those same lines, so Jennifer, is that yes, the diagnosis we know it has increased dramatically, but nowhere near the increase in the waiting list for the Ontario Autism Program.
Right.
And so that there's this really huge disconnect there, I think.
Yeah, that's right.
Jackie, you want to say something also? You just go ahead and unmute yourself.
Yeah, I might pipe in there, Jennifer. That's great to hear what Pond is doing. I might also then add this idea of advocating with what already exists and this age between 4 and 6, because we're seeing some of these early intervention programs go unfilled because of the time it takes to get through to clinic and, just from the natural history when flags get identified in the system we have. So knowing that sometimes advocating within what are structures that already exist doesn't necessarily mean adding a lot of dollars to the pot per se, but looking at how we can make use of what's already there, especially if there was a precedent for a recommendation to align early intervention truly with that 0 to 6 early intervention timeframe, right?
Yeah, and that's why we're asking for a meeting, and it's as well as Empire Kids, ask for a meeting and to resurrect things and take a look at that.
Because we're certainly seeing that here at TBCC, and I'd
Yeah.
be curious what other treatment centers are seeing that way too.
And the other thing we're hearing from the psychologists and pediatricians about this is that even if you get to the point where you get money, one of the problems the families are having is because everything's been so delayed, there's less and less private providers even available.
Yeah.
Because they're private, they weren't making any money because they weren't getting families coming to them. And so they've, decreased what they have available. So it's the whole system is, totally inattainable right now.
Well, absolutely. And I think that, I was glad to hear what Nicole said earlier, because I do think that people without autism spectrum disorder, but who have other severe needs, have gotten the short end of the stick in a lot of
Mhm, mhm.
in a lot of ways, unfortunately.
That's right.
And again, I think it's the people with those really severe needs that are often really severely impacted in their families and the quality of life and things. So if I can just figure out how to carry on. Okay, so let me go back to my slides here. So the other issue then is around hospitalization. And I think at times, because of problems with aggression and self-injurious behavior, and I'm talking about kids again with these severe behavior problems, and a limited resource in terms of behavioral intervention and supports, that sometimes families feel they have no options other than hospitalization for their child. And this, I think, and I couldn't tell you exact numbers, but my sense is that in the last 2 years, I've had more patients of mine admitted to psychiatry units in hospitals than I had in the previous, 10 years combined almost. I would like to believe that's got nothing to do with me as a physician. I hope that's not the case, but I think it's more about the lack of services for those really kids with severe problems and the impact they have on families and people getting hurt and things. And so, however, and this, I guess I have to say this opinion reflects myself only and not my employer or anybody else. But I think in general, general hospital psychiatry inpatient units are not intended for people with autism spectrum disorder or intellectual disabilities, right? I don't think they're set up for that. They're not intended for that at all. And I'm not sure how much difference it always makes in the long run. So first of all, we're talking about autism spectrum disorder or intellectual disability and aggressive or self-injurious behavior. First of all, these are not conditions that are, quote, treatable in the same way as depression or anxiety or schizophrenia things, that there is no clear remission or something like that we can point to in other disorders. And so really, what is the goal of admission? And further, I think the milieu and the way wards are set up is not developed for the needs of people with autism spectrum disorder or intellectual disabilities. They don't have the same options, the same supports. And I think for nursing staff and other staff on these, I think it's a huge problem too, because it's really a very different skill set than is required for nursing staff or other people. And often they are shorthanded and short-staffed and with some very, very difficult people. And what I've seen a number of times then, and we saw it this past summer with a patient who ended up in restraint for significant periods of time because of self-injurious behavior, but and the inpatient unit wasn't really sure what they could do for this person and had real difficulty managing the behavior if they weren't in restraints. And again, I may be flipping the script, but I often will tell residents and trainees, I think that generally people with intellectual disabilities should not be admitted to psychiatry units in hospitals because they're not necessarily going to be all that great. They don't solve the problem. I guess suppose they make people safe for a time, which is great, and can give families respite. But that's not what they're intended for. And sometimes the length of stay can become incredibly long. I've had several parents when their kids were admitted to hospital would then say, I'm not taking them home. And so they're there for a very, very lengthy period of time. And what I've heard, and this is purely anecdotally, the statistics may be completely wrong, but on the adult inpatient unit at Victoria Hospital, in their more secure area, oftentimes a number of beds are occupied by people with intellectual disabilities or autism who have been there for extended periods of time. And so they're in a place that's not really set up for them. It's not equipped for them. It's not ideal for them, but they're also taking up beds that may be more appropriately used by others. And I think this is a huge problem. And it's so essentially hospitals are becoming the de facto sort of place for people, but they're not intended for that. And it's not ideal in any way. And again, as I said, the admissions can be very, very lengthy with little resolution of the admitting problem and with further problems. And so readmissions for people at times within a fairly short period of time. So if I can wrap up and then we'll have discussion. I would say if we go back to was the best of times, was the worst of times, I think probably we could say that the first sentence of Dickens's book should actually be it was the worst of times or the worst of times, because really we have increasing demand and need for services and less availability, unfortunately. And it's going to take something has to be done. I just don't know what it is. I've looked into other centers and how they deal with acute emergencies or acute situations in the developmental sector, and there's really I haven't come across anywhere that has an ideal way of coping with that. And it's a huge problem that's only going to get bigger, I think, as time goes on. So I will stop babbling there, and if there are comments or questions, feel free, please, to say so. So if I could just say, so Svetlana Ishakova at Parkwood Institute made the point here that right, issues in there. So if people are admitted to hospital admissions, it's a totally different environment than from the home, and behavioral work done in the unit does not always transfer to the home environment. I think that's absolutely correct. So I've seen that as well. But also, I think we have to remember that the staff who are at and working on an inpatient unit or residential program, that's their job. They're there for 8 to 12 hours a day, but then they can leave. Whereas parents and families, they often have another job and then come home and have to deal with the behavioral difficulties. So often are more tired and burnt out at the end of the day than staff in any kind of any hospital or residential program. And I think the toll these kind of things take on families is enormous, and I think we often don't appreciate it enough. And I think on siblings also, I think are often this sort of forgotten aspect of these things at times. Dr. Neal, if you would like to unmute yourself.
Yeah, I was going to say too, I think even in capacity, when I look at our practitioners that are coming out of our behavior programs and things like that, they're used to sort of like early intervention stuff, and they don't have the skills for these kids that are getting, funding later on that are maybe more complicated, or there's different types of needs. And then we're pulling them out of school to go to behavior therapy because now they're 9 when they're getting their funding, where before we had this like intensive early model where they're all getting it before they enter school. So I think there's a real need for a lot more supports in schools. If this is when they're going to get core clinical funding, it doesn't make sense for me to pull a kid out of school for a bunch of hours when they should be in the school getting supports there.
Yep.
So I think we really need to rethink that. And then I think the capacity for the behavior supports, there's not a lot of people with expertise in more significant behavior needs, right? Like the students that I'm training are not experienced in this and are not getting mentorship in it in the same way because there's not a lot of settings for them to do it in.
So then, Nicole, what I've heard from 1 or 2 other BCBAs is that, the same sort of thing that people, I don't know if the educational programs or somebody else, but they focus more on the increasing skills or adaptive behavior as opposed to reducing maladaptive behavior. And I realize at some level it's opposite side of the same coin, but that's what I've heard is that people don't have the same level of experience or education. And so there's just not the same level of availability of services. I mean, is that correct, do you think?
I think so. Well, and like now they're doing placements in these private providers, and private providers don't want complicated clients because they're expensive, right? And families then don't have the funds to pay for it, right? So there's this, since we've switched to this private provider model, I don't know where these individuals, aside from like urgent response, but even around here, that's going to private agents. Like in different jurisdictions, they do urgent response differently, and our students are not sitting on inpatient units doing their training because there's not a ton of behavior analysts to mentor them. It's complicated, and so there's a real challenge in how are we developing a workforce to support with this as well.
Right. So what I have advocated here at CPRI for occasionally over the number of years, and was talking with somebody in management today about, was that I think that when it comes to really severe self-injurious behavior, I don't think there's any great place with sort of a real nucleus and the critical mass of people to address people with really severe self-injurious behaviors. And that I think that there needs to be a unit somewhere, I would love it to be here at CPRI, but somewhere to address those people, because I think that the toll on people's health obviously is tremendous. We worry about long-term, chronic traumatic encephalopathy and on their families, but also on people working with them, because watching people with severe self-injurious behavior is pretty terrible for anybody. But I think there's a real need for that, because that they end up requiring huge amounts of services, and the dollar investment is tremendous. We had a boy here a number of years ago who had been at a hospital in Ontario, let's say, in restraints for about 6 months prior to coming to CPRI, because of pretty severe self-injurious behavior, and just the expense of that, and the occupying of a bed that really wasn't intended for him was just tremendous, and really disheartening in a lot of ways.
And the hard part is there's really good stuff that can be done. Like
Yeah.
that is the sort of bread and butter of traditional behavior analysis. And yet, at least around here, I have a hard time saying, like, where would you go get mentorship to learn about how to do this, aside from maybe like some work at CAMH and things like that. But it's very challenging to think of
Yep.
where I would send people who were interested in this to get mentorship.
So, but Nicole, what has happened then? Because I think in the past there were a lot more. I mean, they weren't called BCBAs at the time, I think. But if we think about a guy I never met here, Dieter Blinder, who was here in the 90s and before that, and then Pancho Barrera, who I think had a lot of experience working with people with severe self-injurious behavior. What has happened with, like, why haven't people followed that?
Well, that's what I was saying around now, with the model is that that a lot of the spaces where people end up working, right, is now if it's mostly core clinical, right, then these are private providers primarily. And so private providers are going to do things that are, cover their bottom line. Which is not severe behavior. That's not the stuff that, a kid that just needs to learn a few skills, that's easy. And I can train lots of people and I can do that. But I don't think there's the same incentive to support really significant behavior needs in a private sort of model, right? Like we hand people money and you say, go pick who you want. And it's sort of the people do set up shop for whatever they want to offer. And if they don't want to offer severe behavior services, they can say, no, I don't offer that.
So, but what's the way around that then? Should the government say that if anybody's receiving money, they have to provide some level of services to people with severe problems?
Yeah, or earmark funds for it or something like that. Yeah, I mean, or we need to have a direct service model where we offer it and have quality standards, and we say that we can't turn people away. I mean, that's what it was before. Nobody was getting turned away. Nobody, there were benchmarks that you had to meet. Now there's no progress. Like you even mentioned that they had to make progress. Well, there's no progress monitoring now. I don't have to prove that I taught anybody anything to get reimbursed.
How did we end up in that point, though?
We decided to switch to a private pay model. I don't know, that's what they decided, right? I think that's a fairly typical conservative approach, that it's better to hand the families money and let the market kind of figure it out versus a highly regulated centralized model.
With the problem being then the people with I don't want to say the greatest needs, because I don't know how we define that, but people with more severe problems, let's say, are the people who get left out in that.
Yeah. And I mean, there's the urgent response, but I don't find that all that helpful for, like a 12-week caregiver, like it's supposed to be parent training that we deliver to them. I don't know in crisis what parent is learning parent training skills.
Well, but also, I think I was under the impression that it used to be 12 weeks. I thought that it had actually been lowered to 10 weeks or 8 weeks or something like that.
I don't.
This is what I hear from families, so it may not be accurate.
But they can recycle through it, so they can do it a bunch of times. But my experience is that the model for somebody who's in a crisis state, it's challenging to impart skills in a short period of time, right? It's like you have to stabilize first, and then.
Well, I think especially for parents who have been, have a child with severe behavior problems and a really marked disability, I think it's really, really difficult. And again, I think if we go back to the boy I was talking about earlier, that I think 12 weeks is great, but that's not going to be anywhere near enough time to do a proper behavior analysis and develop a program and then implement it. It's just not enough time.
Yeah, and not in a right? Like
Yeah.
I would want the therapist there and then transfer to the home kind of thing. Because again, if you're at the point of needing an urgent response, you're probably not thinking about learning a whole bunch of skills and implementing. Like you're not, you're in need of respite. That's what you're after. That's why you're getting support. And so they're not, I don't always think people are in the right state of that urgent response to be getting a bunch of transfer of skills for how to deal with severe behavior that their child is experiencing.
That's a really good point, Nicole. I think people have to be in a good spot to learn, and if they're dealing with other things, they're not going to be. If I can switch, Claire, if you want to, you should be free to talk.
Yeah, I think those are all really good points, and especially the last one about respite, because that is actually not very available either, and that is sometimes what the families need to be able to handle the behaviors. But my other comment was going to be that when families have been able to access urgent response, I actually have found it quite helpful for the families, and especially if they can kind of sign up again. So they get a series of things to kind of work on, and then they can have some time to do that and then work on something else. But the problem is it's actually quite hard to meet the threshold for urgent response. So I guess that would be one thought, is to have a bit more of it available so that the threshold can be lower so that people can access it while they still have the energy to do something.
Or different forms of it, right? So, because I think you're right that I think that respite's a huge chunk of it for families. Finding respite workers is not easy, and I'm not sure how some families are able to do it because some people are better at accessing services. But I've got several patients now, I think through complex special needs funding, who have 2-to-1 respite workers most of the time, and frankly need it because of their behavioral issues. And I think Diane Rogers, one of the social workers here at CBR, had a great point here in the chat, where the people caring for kids with severe behavior problems or aggression potentially going to have post-traumatic stress disorder, at least evidence of symptoms of it. And I've wondered the same about siblings of people that we see with severe aggression. And as Diane pointed out, their ability to implement strategies prior to addressing the problems and addressing their own difficulties is going to be really limited, unfortunately. And I think, Pamela Block's point again is really well taken. So, that it's unfortunately families shoulder the gaps in systemic support, but I don't envy the government in any way this, because I think that no matter what they do, somebody's going to be upset and disappointed because their kids are not going to be getting what they think they need. But I think what they have to come up with is what the purpose of the program is really, and what the goal is and who they want to serve. This has been a great discussion. I appreciate everybody's comments. Is there any other questions or comments or things anybody else would like to say before we wrap up? Okay, well, again, thank you everybody for coming. If people can fill out their evaluations, and if people have ideas for other talks, please send them to Jason. And there will be a link that Jason is about to post in the chat. If you could fill out the evaluation, that'd be fantastic. It helps us out a lot. Upcoming presentation we have. So on March the 11th, so a month, 4 weeks from today, Anahita Maybody and Melanie Burr from Light Health Science Center are going to talk about advances in genetic assessments in developmental disabilities and next generation tests. And then also we have on April 16th at noon, we have our annual continuing professional development day. There's lunches included, as well as continuing professional development credits. It's at Ivy Spencer, I believe. If I'm wrong, Jason, correct me, please. But there are going to be 3 speakers. So Jennifer Barr, from the Department of Psychiatry at Western, is going to talk about sleep disorders. Dr. Ibarra is going to talk about obesity in children and adolescents and approaches to it, because we know that it's a more problematic, it's more widespread in people with developmental disabilities. And Jason, I hate to admit it, I forget who our third speaker is that day.
Joan Gardner.
Oh, good God. All right. Well, now I'm never going to hear the end of that, am I? So I apologize profusely, Joan. Do not take it as anything intended. And Joan is going to talk about language disorders and the recognition of them and assessment of them in people with developmental disabilities on that day. So if any people are interested in attending, it's on Wednesday after starting at noon on April 16th. And if you go to our website at ddp.uwo.ca, so DDP being Developmental Disabilities Program, so ddp.uwo.ca, there's a registration link there, and we still have room for people. And the other thing I just wanted to make sure everybody's aware of, so we have an annual competition, the spring, a grant competition, at the Ben Goldberg Research Award, and the deadline for that is March 31st, and information on that and application instructions can also be found at ddp.uwo.ca. So again, thank you everybody for attending today. This was a great discussion, I think, and really food for thought for all of us, and I appreciate it, and we'll see everybody next month. Okay, take care.